Right. So starting with a bit of stuff on fluid distribution, just because when I've been doing a lot of my reading and the sources I've used for this, they kind of start by going back over it. And I thought it would be quite a useful bit of a recap because it's so determined by electrolytes that you kind of have to put them hand in hand, really. So to begin with, this is basing it off of a lean or a normal looking male and female, not someone who's just sat and eating their body weight whilst in quarantine, like I definitely have. So we know that water is a heavy percentage of our body weight, but in a normal lean female, it should be about 45 to 50%. And in a normal lean male, it's about 50 to 60%. Obviously, it isn't just kind of like sitting there in a pool somewhere. It's either divided into what we call the intracellular space or the extracellular space, which we further divide up into interstitial fluid and plasma, obviously plasma being that which is going around in your blood vessels. So about 35% is in intracellular fluid, and it's mainly potassium, which is your main intracellular electrolyte, if you think of it that way, which determines the osmotic pressure in there. The osmotic pressure just being like the pressure that's drawing in fluid. About 12% is found in the interstitial fluid, and it's mainly sodium that's determining the concentration there. And about 35% is found in plasma, and this is mainly determined by proteins. So things like albumin, sex hormone binding globulin, you can probably name quite a lot yourselves. And then regulators of this. So to throw back to first year or second year stuff, you've got your intrarenal receptors. So the ductoglomerular apparatus on the afferent arteriole, which obviously when that's activated is going to activate your RAS system, which again, you can find a ton of like really nice pictures of if you want to. I think in the handout that I've done for this, actually, I've taken a picture of the textbook that I used mostly when I was going through this. So I've got a big picture there if you really want to break down some of the RAS stuff, just to remind yourselves. And then you've got some extrarenal receptors, which are receptors you find in the carotid sinus body and aortic arch, and they respond to slight reductions in circulating volume. They're a lot more sensitive, increased sympathetic activity and increased catecholamine. So that's obviously your neurotransmitters like adrenaline and noradrenaline. And you've also got volume receptors in the atria, and when they're stretched, because they are stretch receptors, they will release AMP or atrial natriuretic peptide. You've also got aldosterone, which is responsible for your day-to-day secretions of sodium, and antidiuretic hormone, which is responsible for determining how concentrated your urine is and how permeable your collecting ducts are to water through aquaporins. So hopefully that's just a little bit of revision for you there. In increased intracellular volume, this is generally where patients tend to present with what you call signs of fluid overload or edema. And edema tends to occur when we've got expansion of the extracellular space by at least 2 litres. Probably actually would have been helpful there if I'd inserted what your normal maximums are in terms of litres, but I can go back and work on that afterwards. But yeah, tends to happen when you've got extracellular volume increase of about 2 litres. Normally what you see is the ankles swelling first, because if you think about it in the sense of gravity, that's the part at the bottom, and most of us are spending our time either walking around a little bit or sitting down with our feet on the ground. If you get people with facial edema, this tends to happen in the morning after they've been laid in bed all night. Again, it's a sort of gravity related drainage thing, and you tend to get sacral, like that sacral pit edema that we test for in respiratory examinations in your bed-bound patients, because again, gravity. And you can also get expansion into interstitial spaces, eventually causing pulmonary edema, pleural effusion, pericardial effusion, and ascites, and the all sort of organ associated edemas or effusions. Like the worse and worse it gets. Obviously, like there's certain types which are more associated with certain systems, certain types of failure, for instance. And some other signs you can get of it when you get expansion of blood volume includes raised jugular venous pressure, cardiomegaly, added heart sounds, basal crackles, and raised arterial blood pressure. And some of those you might recall, so things like basal crackles, that's obviously a sign of when you've got pulmonary edema. So some of those are kind of going hand in hand. And it's usually due to some kind of sodium chloride retention, which is then as the main one of your main draws of osmotic draws of water, is going to cause you to be overloaded. It's not usually due to increased oral intake of salt, because although that can kind of increase your blood pressure, you're normally going to compensate for this with like homeostatic mechanisms. So causes of this could be heart failure, liver failure. So I've got headphones in and someone just buzzed me on Facebook and it was really loud. Estrogens can cause a slight, a very mild salt retention because they've got a bit of an aldosterone-like effect. Non-steroidals can activate the VAS system, and it's particularly, it doesn't tend to happen normally in a normal healthy individual taking the occasional bit of brufen, but it can worsen retention, say in someone who's got cirrhosis, heart failure, or particularly in someone who's got renal artery stenosis. I'm not going to be able to say this, but thiazolidinediones, I think, which is a medication that we use in type 2 diabetes, and calcium channel blockers. We know like one of the key side effects that you tend to get with those can be ankle swelling, which is why a lot of people come off them. So treatment, and a few notes on diuretics, because again, I thought it was quite helpful revision for you. So to treat it, obviously treat the underlying cause. So if it's heart failure, treat the heart failure, for instance. Restrict the salt intake, so don't exacerbate something that's going to increase the pull of water into their various spaces, and consider using diuretic agents. So you might want to put them on a loop diuretic, which is probably our mainstay of them. So this includes like bumetanide, furosemide, and this is going to stimulate excretion of both salt and water by blocking the sodium potassium 2 chloride channel in your thick ascending limb of Henle. Again, anyone who's like, oh my God, it's not on the slides, don't worry, I have put it in my notes, so you can read it off there when I share those later. You can also, as well as the diuretic effects that you get from that, you get this venous capacitance. So patients can improve really quickly just from that before the actual diuresis takes place. And just some things to watch out for when you're using these is that you can get quite a lot of urate retention, so increasing your risk of gout, stones, things like that, resultant hypokalaemia, hypomagnesaemia, decreased glucose tolerance, so you can kind of induce some sort of diabetes-like state. Allergic reactions are common, particularly allergic reactions that can cause a bit of a nephritic picture. Myalgia, ototoxicity, and it can interfere with lithium excretion and lead to toxicity. Thiazide-like diuretics aren't quite as potent as your loop diuretics, and they block the sodium chloride channel in your distal convoluted tubule. You've then got potassium-sparing diuretics, which obviously are fantastic if we aren't wanting to cause hypomagnesemia, like you get quite aggressively with loop diuretics sometimes. And these include things like aldosterone antagonists, so spironolactone and perinone, and you also get amiloride. And very often you might prescribe them concomitantly just to counter, so you get like the powerful kick of one diuretic countered by the potassium-sparing effect of the other. And carbonic anhydrase inhibitors, you tend to use these not so much when you're looking at things like fluid overload, but you might use them, I know you use them like glaucoma and things like that. And you can also get people that are quite resistant to diuretics, in which case you've got to consider either really high doses, using IV administration, or just go into like alternative means altogether. And it can be because there's poor bioavailability due to underlying causes, reduced glomerular filtration rate, or they get some kind of activation of sodium retaining mechanisms that just render the diuretic ineffective. And decreased extracellular volumes, this is obviously when your fluid's underloaded. Patients can present with symptoms of obviously like really bad dehydration, muscle cramps, nausea and vomiting, and postural dizziness. And a lot of those symptoms aren't so much to do with the lack of water that they've got, it's the associated electrolyte imbalances that they get that comes with that, which tend to be relative to the levels of hydration. So they'll present with, it usually tends to be that patients kind of have this sort of like pseudo hyper blah 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 because their the level of water is really low in terms of a ratio to the levels of solute of different electrolytes they've got. And in really severe cases, this can present with hypertension, which can impair the flow to the brain, and they get kind of signs of confusion, and they might end up in a coma eventually, as everything in medicine seems to end with coma and death. And signs of it include reduced skin turgor, so that's obviously like where you are pricking at the skin, you hold it to see how long it stays up for, and then on a normal person, if you just try to do it on yourself now, if you try to do it on your arm, for instance, your skin should just like snap straight back. And the older you get, because you lose elastin in your skin, it tends to do this less and less. So if you want to try and see what it looks like on you if you were dehydrated, go try it on some old person that you might be living with. Otherwise, the best places to check generally are like the forehead and the anterior like triangle in your neck, because for whatever reason you lose elastin from there quite as much as you do from your peripheries. And you can also get like venoconstriction with loss of fluid anyway. So it's basically there's less blood, there's less water going to those areas, the water's drawn out of those cells, the skin can't support itself as much. You get those sunken eyes and then dry mucous membranes as well. And it can also present as postural hypotension. That's when the body starts to lose its ability to compensate for like the loss of volume circulating, a low JPP that you might even see when your patient is led down or like with a head upside down, peripheral vasoconstriction, like the associated signs of that, like cold peripheries and things, and tachycardia, because that's like the one way that you actually have of compensating. And different causes of that could be autonomic failure. So by that, I could mean things like diabetes, aging, Parkinson's, or things that are going to like cause deposits like amyloidosis. And you can also get drugs that interfere with the autonomic nervous system, in particular tricyclic antidepressants. You can also get drugs that interfere with peripheral vasoconstriction, so nitrates, things like GTN, calcium channel blockers, prolonged bed rest, because the longer, okay, let's say you've got an old person who's sitting in bed for a long time with their sacral edema, the heart's not going to have to compensate for the changes of normal day that we might do as we're moving around, and it'll just lose those kind of reflexes to keep itself going, and decrease circulating volume. So you might get this with hemorrhage, burns, sepsis, different types of shock, things like that. Renal and gastric losses being big ones as well. Okay. I'm just going to apologise because I kind of went through a bit of a phase of doing some horrendous puns as I was going through this. So hopefully they make you giggle. If you think they're horrendous, I don't care. So yeah, sodium imbalance to start off with, because this is the most common one that you tend to see in hospital. So something like up to about 35% of patients will get hyponatraemia. So hyponatraemia is the main, out of all your, well, there's only two. Out of hypo and hyponatraemia, it tends to be hyponatraemia that you see, just because it occurs more commonly. But in health, we should have between 135 to 145 moles per litre. Obviously, in an exam, they're pretty much always going to give you some kind of chart that has your normal values on it. They'll tell you when something's abnormal, but I always think it's quite a good idea to have a ballpark figure anyway of what they are, just because then you're not relying on that. That's not to say that they ever will be evil and not give it you, but the one time that they don't or something, it's reliable. So yeah, you tend to lose about 10 to 20 moles per day, sweating, weeing, whatever else, but we also consume about 100 to 200, but most of this is excreted through the kidneys. So that just kind of goes to show you how salt excessive our diets are, really. So starting with hyponatremia, because as I've just said, it's the most common. This is where you've got sodium less than 135, but you can kind of classify it based on its symptoms, really. So if it drops below 130, your patient might be a bit headachy, confused, irritable, presumably due to kind of impacts that sodium has to do with your pathways in the brain, or your blood supply to the brain and things like that. Below 125, you get severe neurological symptoms such as seizures, and below 115, it's that classical coma death thing going on. And as I said, it's the most common biochemical abnormality, and up to about 35% of patients can develop it. You can get this thing called pseudo hyponatremia, where you've got patients that have really high lipids or high proteins that somehow mask that their sodium is actually normal, and it'll show up as low. And this generally isn't something to worry about. It's just something that's going to show up on their blood sample. Okay, some of that I've said there, but so some signs of it: you get decreased tendon reflexes and muscle twitching, which is something that you're going to see. In fact, all these symptoms you're going to continue to see again throughout this presentation. So I apologise that it's just there's no simple way of like really attributing some of them to different ones. And some symptoms that you're going to see are anorexia, so reduced appetite, tiredness, thirst, irritability, headache, coma, convulsions, like we just said. So this is one way of dividing it up. I've divided it up based on cause into the whole euvolemic, hypovolemic, hypervolemic thing. But I found this, which was quite a good way of thinking about what potential causes could be. I think the way that I sort of revised this in finals was just have a rough idea of like what conditions from what I've read about them might have hyponatraemia as a symptom. I wasn't that good at actually remembering like a big, like really enough list of causes. It's more that if you named a cause, I could go, oh yeah, that was a hypo or a hypernatraemia, hypokalaemia picture. So it's generally quite good, especially with like your endocrine conditions, to have a rough idea which one's a hyponatraemia, which one's a hypernatraemia. And I think again, if endocrine teaching is something that's quite useful to you guys, just let us know and it can be sorted out. So yeah, I'll go into a little bit more about, I don't know if you can see my mouse there, but like I'm circulating the one that's talking about urinary sodium, because that comes into play in a second. But as you can see, there's a lot of different causes, and we tend to base it upon whether or not the patient is, what their hydration status is. So yeah, we tend to classify it via fluid level. So if you've got hyponatraemia with hypovolemia, that's where you've got clinical evidence of fluid depletion. You can classify it into extrarenal, so that's whether their urinary sodium is greater than 20 moles per litre. And this could be things like vomiting, diarrhea, hemorrhage, burns, pancreatitis, so things not involving the kidneys. Or it could be renal, so the urinary sodium will be less than 20 moles per litre, because we're not excreting sodium as we should. And this could be due to osmotic diuresis, so hypoglycemia, severe uremia, diuretics, or adrenocortical insufficiency. Again, not listed the causes just for the sake of not making this slide mad, but it is in the teaching handout. And to manage this, you obviously want to try and manage the lack of the dehydration that they've got going on as well, but you tend to just give these patients 0.9% NaCl, and you're going to give it them slowly. So you're usually going to give it them at about over, like, I think I've included it later in the teaching, to be fair. I'll explain why you don't want to give it really quickly soon, but obviously you don't want to precipitate either a bad side effect, which is osmotic demylination syndrome, or you don't want to swing it the other way and cause hypernatremia by accident. In patients with euvolemia, so that's where the fluid status is normal, but they still have this hyponatremia. The most common cause tends to be that you've got a patient that is coming around from an operation, and you've overgenerously infused 5% glucose, which causes this increased ADH secretion, which is exacerbated by increased ADH secretion that they get in response to stress, and precipitates this drop in their sodium levels. You also get it quite a lot with marathon runners who they're rehydrating themselves well, but they're not replacing their electrolytes as they should, even when they're using things like isotonic drinks. Also happens quite a lot with symptom of inappropriate ADH secretion, which I think most commonly tends to be a paraneoplastic syndrome, but would have to double check that when I was doing some endocrine stuff with you. Ecstasy, it's a side effect of, and any drugs that are going to alter ADH in some kind of way or act like ADH. And the way to manage that is to restrict water intake and give hypertonic saline if it's an acute picture, so such as a marathon runner who's coming in collapsing because their sodium levels are really low. And patients who've got fluid overload, so it tends to happen with heart failure, liver failure, or oliguric kidney disease. So oliguric just meaning that they're not making anywhere near enough urine as they should. And it happens with hypoalbuminemia as well. I'm not sure, I've not written that one down. And the management for that is restrict your fluid and salt and consider diuresis. So generally, like, easy enough management, rehydrate them if they need it, give them a diuretic if they're fluid overloaded, restrict their salt intake. And osmotic demyelination syndrome, so I talked a little bit about this or hinted about it before. It used to be referred to as central pontine demyelination, but however recently they've renamed it. So if you see or have any notes on central pontine demyelination already, this is just the other name for that. And it's what happens when you rapidly overcorrect hyponatraemia, and you get basically the brain starts to lose, it's lost these organic osmolytes very quickly to adapt to the initial hyponatraemia, and then when it regains these too quickly, you get this like shrinkage of the cells, the blood-brain barrier gets more permeable, an influx of immune cells like cytokines happens, you get microglial activation, and for whatever reason they attack your myelin and you get demyelination. So you want to aim to not have your plasma sodium concentrations in patients with hyponatremia rise by more than 8 moles per day. And there's some factors that predispose to this as well. So patients who have a background of alcohol excess, cirrhosis, malnutrition, hypokalaemia, existing hypoxemia, or I don't know what all CNS is, but I think that is CNS hypoxemia. We'll check. So moving on to hyponatremia. This is where you've got sodium over 145 moles. It's a lot rarer than hyponatremia, and it tends to indicate that they've got a lack of water. But we still do classify it by hypovolemia, euvolemia, and hypervolemia, but it's more common in patients that have just all of a sudden lost a load of water, but haven't lost their salt in accordance. So features of it, can be nausea, vomiting, fever, confusion, spasticity, flushed skin. So flushed skin is probably your unique one here. Hypertension, which we know to be associated with, at least in the long run, with high salt intake anyway. Irritability because of its CNS effects and signs of dehydration. And causes, so you could have GI losses if it's hypovolemic. Again, these are like very similar causes to hyponatremia, which it makes it as confusing for you guys as it made for me back when I was revising for finals, and it makes it for me now when I'm trying to think of ways to help you differentiate it. But I think the general rules are that like both these causes where they've got in common, they could lead to either, and it kind of just depends on the patient, and you've got to read off what their blood results are when you do you're using these and stuff, and just see what's going on. So in euvolemic, it's people that aren't drinking enough, or people with diabetes insipidus where they're just peeing out loads of urine that doesn't have any osmolytes in at all, and fever. And you get it with hyperaldosteronism and with intake of hypertonic saline as well. So to manage it, treat the underlying cause, so treat any diarrhea, vomiting, things like that. Encourage water consumption, or consider giving 5% dextrose IV slowly. And if they're hypovolemic, you'll consider using 0.9% saline. And you want to guide your efforts, as you would with any of these, to be fair, by the urine output and the plasma concentration. And with this one, it's obviously not central pontine demyelination. You can see what the name was there when I was revising it, that you're going to be worried about, but you want to do it slowly, otherwise you're going to risk cerebral edema from hyponatremia. So next one, potassium balances. So normally potassium is sitting somewhere between 3.5 to 5 moles. You eat about 80 to 150 moles a day. WHO recommends that we reduce this to 90, but again, we all like eating a lot of things that are salty. And uptake stimulated by insulin, beta-adrenergic stimulation, and theophylline. And it's decreased by states of acidosis because you get that switching of potassium for hydrogen ions across cell membranes, or cell damage or death, such as what you get with like tumor lysis and rhabdomyolysis, where you get rapid, massive intracellular release, release from inside cells of potassium. So hypokalaemia is the status where we've got it over 5.5. But this can very quickly, if it shoots to above 6.5, become a potential emergency, because it's at this level that you tend to get this myocardial hyperexcitability, and this can lead to ventricular fibrillation and cardiac arrest. So if you've been doing all sorts of stuff on your arrhythmias, you'll probably have seen things about hypo and hypokalaemia to death, and that's probably the best place if you're going to revise this in isolation to bring it in. It can show up on a blood sample quite a lot, even with no other symptoms and signs. And this is generally not because the patient actually has true hypokalaemia. It's generally because you've either had lysis of cells during venipuncture, or the patient's been doing some kind of abnormal muscle contraction, which causes like a local release of K+. I think it does take quite a lot for this to happen, but generally when they're encouraging patients not to like fist pump loads, because you can get this like aggressive breakdown of cells. It's one of those quite far-fetched things, but the literature apparently suggests that it does happen, so we'll go with it. And some signs and symptoms, which you can see a few of like nicely animated there on the picture on the right, include your arrhythmic, fast arrhythmic pulse, chest pain, muscle weakness, palpitations, lightheadedness, decreased cardiac contractility, absent or decreased tendon reflexes, and paresthesias. And if it's severe enough, you can actually cause the patient to have this flaccid paralysis that extends upwards. So sounds a little bit like Guillain-Barré syndrome, but never heard of it or seen it, but apparently that does happen. Now, ECG should pretty much be one of your first investigations when this happens. And the signs of what can appear are tall tented T waves, small P waves, increased PR interval, wide QRS complex, and the worse and worse this gets, you precipitate the likelihood of ventricular fibrillation or asystole, which again, if you guys have done any cardio, you will hopefully really know about. But this image here on the left just sort of breaks down to you kind of at what values these ECG abnormalities are going to appear. So hopefully with most patients, you would only ever see it as slightly peaked T waves. In really bad patients, obviously you're going to get that atrial fibrillation, blockages, asystole, and all kinds of nasty things like that. So causes and treatment. So we have obviously said it could be artifactual if you've got a patient who's had some kind of dodgy blood sample taken and it's hemolyzed a little bit. It can also happen if you've got EDTA anticoagulant in for blood count bottles, or if the sample is delayed in analysis, because then you're going to get more and more breakdown of the red blood cells in that. You can divide your causes of true hypokalaemia into decreased excretion, increased release from cells, and increased exogenous load. So that's load coming from somewhere else, or spurious. So it's generally just happening. And the common causes that I could really think of to draw your attention to were obviously like it's a big symptom of AKI. It can happen with a lot of drugs, so particularly your non-potassium sparing diuretics, your non-steroidal anti-inflammatories, and your ACE inhibitors. It can happen with heparin because heparin inhibits some of your aldosterone secretion. Cyclosporin, you get it with acidosis generally, rhabdomyolysis where you've got tumor lysis where you've got again death or splitting of certain cells. Happens quite a lot with massive blood transfusions. Well, I'll say quite a lot, but it's more associated with that than other electrolyte abnormalities. And then you can get this spurious release from things like leukemia, infectious mononucleosis, and just general release from muscles. And there's as there are with most of these as well, you can get familial hyperkalaemia, which generally will be, there's no other signs, they just tend to have high potassium. And some foods to watch that are high in potassium. So I think we all probably know that bananas are pretty high in them, but also oranges, kiwis, avocados, spinach, tomatoes, and in quite a lot of salt substitutes. So a nasty mistake I think a few patients make when they're trying to reduce their salt intake, they've been diagnosed with hypertension, is they go for some substitutes, but actually these substitutes might contain potassium rather than sodium, so they can cause a whole host of other problems by going a little bit crazy on that. And also, if I don't know if this was mentioned at all when you had your, if any of you went to the anesthetics teaching that I think John did the other week, but succinylcholine and other depolarizing agents can cause a release of potassium from your cells as well. Normally it would only be a rise of about a mole, but obviously this can be a problem if you've got a patient whose potassium was maybe sitting at like 5.4 and suddenly it shoots up. They're obviously suddenly at risk of like quite at risk of an arrhythmia, so you want to watch these patients. The way to manage it, if you're going to remember one thing from this presentation, I'd really take this away, because they love to ask how you manage this, because obviously it is considered a medical emergency above 6.5 moles. So the first thing that you want to do is stabilize your cardiac membrane by administering calcium gluconate. Now calcium gluconate isn't going to do anything to your actual potassium levels, but it's going to stop it from having its effects on the heart potentially. You're then going to use, some places will tell you it's just one, but I think most places I've read will tell you it's both. So a combined insulin and dextrose infusion. So that could be extra rapid insulin like you might use in your diabetic emergencies, or some other brand name, and IV dextrose together. Or you might consider using nebulized salbutamol as an alternative, because this will cause some kind of short-term shift of potassium from the extracellular into the intracellular compartment, where although, yeah, you've obviously got the same amount of potassium sitting in the body, it's not in the compartment where it's going to cause as much damage. And once you've stabilized all this a little bit, you want to remove that potassium from the body using calcium resonium, which is, I always think of it as like a binder. So you can give that orally or as an enema, and that's actually more effective because it stimulates this rectal excretion, which is just a lot faster. And if you can't use calcium resonium in your patient, say for instance you try and it just doesn't work, or your patient isn't producing any urine and therefore, like, once it's bound they're not going to get rid of it, consider loop diuretics and dialysis, just to either manually take it out or to encourage that urine production. And you could give concomitant isotonic saline to euvolemic or hypovolemic patients, just to make sure that they don't get dehydrated while you're doing that process, especially if you're giving them diuretics and things like that. So yeah, remember that one. So hypokalaemia. So this is obviously when potassium is below 3.5 moles, and if it's below 2.5, generally this is when we consider it to be severe. And it presents, again, similarly with muscle weakness, hypotonia, hyperreflexia, cramps, tetany, palpitations, and lightheadedness from those arrhythmias, or constipation. I think off the top of my head, this is the one that I associate with bradycardia, but I think it's one of those that, like, there's certain textbooks that will be like, that one's associated with that, but actually it's kind of down to how your body responds, really. So I'd go and, again, would recommend looking this up when you're doing any cardio or like arrhythmias revision and reading. And the ECG signs for this are small or inverted T waves. So probably the way to remember that is, if it's hyperkalaemia, your T waves are really big. If it's hypokalaemia, you've got really small, or T waves going the wrong way around because your levels are so low. Prominent U waves, so that's the little segment here. Hopefully you can see my mouse. Prolonged PR interval and depressed ST segments. And obviously, like, the more you prolong those PR intervals and things like that, you're giving way to things like heart block, and just, yeah, the nasty things that you don't want, really. So causes and management. So again, we can divide the causes into increased renal excretion of potassium, increased aldosterone secretion, because that's going to encourage you to excrete more potassium, exogenous mineralocorticoids. So that could include things like taking aldosterone, or aldosterone-like, sorry, not aldosterone, you know what I mean, renal diseases, reduced salt intake, and things that are going to cause redistribution into cells, so people on insulin, for instance, and GI losses. So generally we're going to use, generally it's potassium sparing diuretics that are most common cause chronically. I meant to put this with hyperkalaemia. There's something there that I just want to double check, but anyway, don't, basically you tend to get it happening quite a lot when you give people IV fluids and you aren't replacing their potassium. So when you've done your fluids teaching with Jenna, I'm imagining she'll have taught you how to, or you'll have learnt this if you had medicine block really early on, how to prescribe potassium concomitantly with your fluids. And the one that they quite like, throwing at you in questions, if you've ever had the 10 ways to kill a patient lecture, which we can definitely sort of do in a rip-off version if you've not had it, is don't give patients ACE inhibitors, potassium sparing diuretics, and NSAIDs all in one go, because you just precipitate really big bouts of renal failure and things like that. And you can also divide the causes into whether it's with or without hypertension, or with or without alkalosis. So to treat it, you're going to use mild potassium supplements. You need oral potassium supplements if it's mild, IV potassium if it's severe. And with IV, you're going to give it cautiously. Generally, try and give it centrally if you can, as opposed to peripherally, because it can be quite irritant to patients. And you don't want to push the patient too quickly into hypokalaemia and trigger like other cardiac dysrhythmias and arrest. So calcium balance. Again, you'll do about this one loads with endocrine. This really, like electrolyte imbalances, is just a thing on its own that I think just branches between a lot of different specialities. But we tend to measure calcium based on what you call your adjusted serum calcium level. So I think it's normally something like 1.6 to 1.8 or something, but the values you would use are 2.2 to 2.6, and this is based on working out the patient's albumin level, taking it away from 4 and timesing that by 0.8, and then you'll add that onto whatever their serum calcium level is. And that's just accounting for the fact that quite a bit of your calcium is bound to albumin anyway, but actually about 99% of our calcium is in our bones, 1% is circulating, and about half of that is in its free or ionized form. And again, like you'll remember this from first year, or bits of it from first year, about the pathway where parathyroid hormone is pretty much responsible for being secreted in response to low calcium, where cholecalciferol comes in, and where it's made by the liver and all that. So I'll let you kind of go into that on your own if you want to. Features of hypocalcemia. So these ones are actually like the really, really nice, easy ones, because you've got rhymes for these. At least if there's rhymes for other ones, when I was looking into, say, rhymes for like hypo and hyperkalaemia, they just got a little bit contradictory. So I kind of stayed away from doing that. But by all means, go find them if that works for you, if you trust them. So we tend to use ones called stones, bones, moans, and groans for hypocalcemia. So with stones, we're talking about renal stones, polyuria, polydipsia, because it can induce nephrogenic diabetes insipidus, and nephrocalcinosis. With bones, we're talking about bone pain and pathological fractures, because obviously as your calcium drops, your bones are going to release calcium to try and compensate for the loss that you've got in circulation. You can get, when moans are concerned, it could be like abdominal pain, and it can also be psychiatric moans, so depression, confusion, fatigue, things like that. And with groans, again, abdo pain, nausea and vomiting, constipation, pancreatitis, and other symptoms that you can get can include hypertension. So you always want to check calcium levels in a hypertensive patient to check that it's not an underlying hypocalcemia. And you can also get corneal calcification. And like how we did with the potassium imbalances, you can also get some ECG features. So your QT wave can be shortened, you can get ST elevation, and you get this thing called the Osborne wave, which is this like sudden upflick in here after your QRS that you can see in the picture. So causes and management. About 90%, so the vast majority of them, are due to primary hypothyroidism. And then the second commonest cause after that is malignancy. So whether that's just because you've got a myeloma, bony metastasis, or you've got something that actually is secreting calcium or parathyroid hormone related hormone, things like that, affects about 10 to 30% of cancer patients. We're not totally sure, but I think anyone that listened to my palliative lecture, you'll know that hypocalcemia is one of your biggest worries when you've got patients who have cancers and things. Some other causes to listen out for are sarcoidosis, vitamin D intoxication, acromegaly, thyrotoxicosis, thiazides, calcium-containing antacids, dehydration, and addisons. And generally, we can sort of look at it by always analyze your albumin levels as well, just to work out is it an issue with the amount of protein circulation we've got going on as well. To manage it, you're going to mostly you can usually manage it just by rehydrating your patient. It normally tends to sort of sort itself out. So you'd normally give them about 3 to 4 litres per day. You might consider using bisphosphonates. So I think this is mainly zoledronic acid. And these take about 2 to 3 days to work. But you can have side effects like esophagitis, flu-like symptoms, osteonecrosis of the jaw. That's the big one that they quite like to have you associating with bisphosphonates. And obviously it can cause hypocalcemia by swinging you the opposite way. You can consider using calcitonin if your bisphosphonates fail, and this is going to inhibit osteoclast activity and increase renal excretion. You might consider using steroids, so prednisolone, if you've got ectopic production from things like sarcoidosis or lymphomas. Denosumab tends to get used sometimes if you've got hypercalcemia and malignancy, and you'll use furosemide if you've got patients who can't tolerate aggressive fluid resuscitation, just to help them a little bit. So with hypocalcemia, the most common cause for this is post-surgical. So patients coming around and for whatever reason they've got a low calcium level. Patients suffering from vitamin D deficiency, magnesium deficiency. Because that's the other thing as well, you've got to remember a lot of these, like the relationship, the very close relationship that you've got between your potassium and your sodium levels, you tend to get as one goes up, the other goes down, or as one goes up, the other goes up. So yeah, you can get this happening quite a lot with magnesium deficiency. Patients that have parathyroid hormone resistance, whether that is due to something that they've got themselves or something genetic. Secondary hyperparathyroidism. So remember, with your primary and tertiary hyperparathyroidisms, they actually cause a hyperkalaemia picture. You get it with acute pancreatitis, sepsis, or other kind of general severe acute illnesses. And your key signs of this, we'll show you, like, I'll show you the little an acronym for remembering it in a second, but you tend to get patients getting this like paresthesia around the mouth. So I think you can generally get a similar thing with when you've got like a little bit, what is that, carbon dioxide overloaded, where you start to get tingling in your fingers and things. So it tends to get like a tingling around the mouth and in the digits, muscle stiffness, spasms or cramps, seizures, shortness of breath, which you're getting because you've got diaphragmatic spasms happening, hypotension, and psychosis is quite a common one as well. And when we're talking about the tetany, you get these two signs that may be positive. So you can get positive Chostek sign, which is where you tap over the facial nerve at the parotid, and it'll cause facial twitching, which you can see in image A there. And Trousseau's sign is where you inflate a blood pressure cuff, which occludes the brachial artery, and then you get this carpal spasming, so spasming of the hand going like sort of upwards back on itself all of a sudden. So yeah, you can get tetany, and you can also get laryngospasm. And the way of managing that is just with calcium supplements if it's not too severe. So this is usually in the form of calcium gluconate or carbonate. And if it's really severe, consider giving it IV. So the way of remembering that is spasmodic. So S is for spasms, P for perioral paresthesia, A for anxious or irritable, S for seizures, M for increased muscle tone, which can lead to things like colic, wheeze, dysphagia, O for orientation impairment, D for dermatitis, I for impetigo, C for Chostek sign, or cardiomyopathy. So yeah, there's a few more skin signs there that we hadn't mentioned, but latch those onto it if you want to. I don't think I'd ever seen those when I've read about some different cases of it, but there you go. Phosphate imbalance. So just two more to go through, and then you guys have had your fill, I think. So normally with phosphate, the normal range is about 0.8 to 1.15 moles. And about 85% of it is in bone. As we all know from first year, it's a key building block, a little bit like calcium is. Its levels tend to closely follow your sodium levels, so it's worth kind of seeing what they're doing when you're looking into this. It's mainly decreased by parathyroid hormone, but there's some other affecting factors. So things that are also in the calcium homeostasis pathway, like vitamin D3, your serum calcium, bicarbonate, the tension of carbon dioxide, can do it, can affect it, glucose, sympathetic activity, and neurotransmitters. And we tend to associate these things in the pathway called phosphatonins. So if you've ever heard of things like fibroblast growth factor 23 or FGF23, that's one of the things that we know tends to get released in response to your phosphate level being quite low. So yeah, there's a little picture that just kind of goes back over that for you if you want to. The thing with FGFR or clotho, when I was reading earlier, that's something which is, the FGFR is like the receptor that's on FGF23, and clotho is like the sort of the cofactor, the substrate that it needs for binding. So if you ever see anything about clotho, it's generally like we use it in reference to, I think it comes into potassium somewhere as well, but it's mostly associated with FGF23 on in phosphate metabolism. But again, I don't know where you're going to get asked about it, but just something that you may come across in reading if you do any more reading on this. So symptoms of hypophosphatemia, generally, like, we're not really going to notice it unless levels are below 0.4, which is quite a bit lower than the 0.8 cutoff for when we deem that hypophosphatemia is happening. And generally the causes are mostly it's going to be primary hyperparathyroidism, if you're going to see it, which is demonstrated by that low phosphate and high parathyroid hormone. And some other causes that might occur are vitamin D deficiency, lack of dietary intake, symptoms causing malabsorption, coming off alcohol all of a sudden, refeeding syndrome. So that's when you've got a patient who's been treated with something like anorexia, and all of a sudden they're eating way too much, like they're overloaded with carbohydrates, and their body has like adapted to surviving on a lower calorific intake. Respiratory alkalosis, severe diabetic ketoacidosis, or treatment of it, because insulin, a little bit like how it works with Hi, if any of you are asking me private questions, by the way, I will answer them just at the end. I just noticed I've got a few there when I checked, but maybe just remind me if I don't. Okay, yeah, you can see the causes there for yourself, but phosphatemia is just this, and hypomagnesemia, which I'm going to touch on in a second, are kind of just some more less likely ones to come across that I thought were worth touching on. Why does this now not want to work? Okay, yeah, so some signs and symptoms are muscle weakness. It can interfere a little bit with your red or white cell and platelet dysfunction, with your function of those, predisposed to cardiac arrest and arrhythmias, and cause confusion, hallucinations, and convulsions. But generally, like, unless it's really low, it's not going to really cause any problems for you. And as with everything, replace it with oral or IV, depending on how bad it is and what your patient's status is, and consider giving calcitriol as well if there's a concomitant vitamin D deficiency. And where hyperphosphatemia is concerned, it's usually due to chronic kidney disease. It's usually asymptomatic. But the problem with it is that even though it's there and it's not causing any problems, it can precipitate into calcium phosphate and cause itching in your patient. But you're normally just going to leave it. It shouldn't be causing any problems. And consider using phosphate binders if you really need to. So finally, magnesium imbalance. So normally magnesium is going to be sitting at about 0.7 to 1.1. It plays a really big role in a lot of biological processes, and generally we kind of forget about it. We sort of sit here and think a lot about salt, your different potassium and sodium, but this is actually really important in lots of enzymatic reactions, in gene transcription and bone remodeling, and it's got a very close relationship with potassium as well. So about 99% of it is in your intracellular compartment, mainly caught up in bone, muscle, and soft tissues. And we don't tend to just lose any day to day as healthy adults. So we tend to pee out what we eat in excess, basically. So symptoms of hypermagnesemia can include paresthesia, ataxia, which I think that's the symptom that I hadn't seen in any of the other electrolyte imbalances here. Seizures, tetany, arrhythmia, carpopedal spasm. So we touched on what carpopedal spasm is when we were looking at hypotonia before. Hyperreflexia, hallucinatory states, confusion and convulsions. You might have some ECG signs, so you might see prolonged QT interval, broad flattened T waves, and shortening of the ST segment. And some causes are, so there's a few genetic syndromes such as Bartter syndrome, which I don't think I'd ever read about for finals, but there you go, which is linked to it. Diuretic usage, use of digoxin, use of proton pump inhibitors, severe diarrhea, ketoacidosis, alcohol abuse, total parenteral nutrition, reduced calcium, reduced potassium, and reduced phosphate. So to treat it, you're going to withdraw any precipitating agents or deal with any other associated electrolyte abnormalities. Give magnesium salts either orally or IV, and you're going to continue these for 2 days after you've achieved normal plasma levels, just to make sure that you don't just kind of excrete them as your body normally would do. And hypomagnesemia. So it normally occurs in acute or chronic kidney disease in patients. It occurs in acute or chronic kidney disease patients who are then given some kind of magnesium-containing medication, such as a laxative or an antacid, or you might get mild cases in patients with adrenal insufficiency. And you don't usually tend to treat it unless it's really bad, so over about 7.5 moles. So causes can include renal failure, hemodialysis with a really high magnesium dialysate, purgatives or antacids with high magnesium. And you can get really bad neurologic depression, hypertension, bradycardia, hyporeflexia. And if it's left to get to this really severe stage, so like over 7.5, you can get this sort of narcotic effect where you get respiratory depression, cardiac conduction defects. I think that should say coma death, not coma CNS coma, but there you go. And to manage it, you're going to withdraw any magnesium therapy and give calcium gluconate. Just a quick note before I let you all go with that. Where have I written it down? You want to watch, when magnesium is depleted. So if we go back to hypomagnesaemia quickly, you can get a refractory hypokalaemia because magnesium normally blocks the things called ROMK channels. So if you're going to lose magnesium, it's going to increase your loss of potassium. So imbalance of one requires close monitoring of the other. So generally, if you're going to treat one, you've got to treat the other and be mindful of the other as well. Cool. I've had a few of you asking just about some sources that I've used for a few of these. So I thought I'd just maybe make a quick note about that all of you can hear. And I might just quickly post about my feedback as well, because I like feedback forms. So generally for these, I can't remember the name of the textbook I use. It's a big fat one that I use like most of my in-depth stuff, and generally like I sit and have a day where I'm just going through that. I think it's Kumar and Clark. Yeah, it's Kumar and Clark that I'm writing a lot of this from. I think there's a lot of waffle in Kumar and Clark that's not necessarily I think it's a bit above and beyond what you need to know, but it's really good for like giving you a grounding in why stuff's happening. It just sometimes takes a bit of a while to like cut the crap and get to what you need to know. So it's a good way of, it tends to be what I've used to decide how I'm going to order the lectures. Oxford Handbook, obviously. If you want a way, it's a little bit dated now, but a guy called Alistair Scott made some notes years ago. If I write his name, if you search, I think it's Alistair Scott. If you search for him on Google, you'll come across there's Alistair Scott Surgery and Alistair Scott Medicine. And I think they're from 2012. And he made these notes in there, like really effective at just sort of summarising the Oxford Handbooks if you don't have access to them, for instance, and adding a few bits in there. So they're quite good. What else? BMJ Best Practice. I think you can get onto it. Either you can make your own account or access it through Shibboleth or whatever it is you use for university. So they're really good. Like I use them when I haven't done it for this one. But when I do the teaching where I make cases, I tend to base them off a mixture of whatever cases BMJ Best Practice has on there. That's another quite good simplified one. Yeah, and Past Medicine. If you like have a Past Medicine subscription, whatever you use, that personally for me was the only question set that I ended up using for finals, because I'm not gonna lie, like a lot of the questions that came up in finals, I remember going through them and being like, I've done this on Past Medicine, I just can't remember the answer. So like I would definitely say do them, but don't like over rely on just knowing them, because it's quite easy to then forget them under pressure and stuff. And yeah, I think it gives you like a good broad knowledge. So like when you get to that point at the end where you're sort of panic revising, I think there was a point where I was literally just taking what was on the Past Medicine notebook verbatim. But there's a lot that I've since learned when I've gone back and done stuff with deeper reading. So I would, in hindsight, recommend starting broad with something like Kumar and Clark, and then cutting it down and then reinforcing it with questions, or doing the questions first and then working backwards, like whichever way works for you. And beyond that, to be honest, odd articles online, if there's something that you really want to know about. That's probably about it, to be honest. Some of this teaching today was taken from some teaching that I had off an endocrinologist last year. So yeah, hopefully that's been all right for you guys. If anyone has any other questions, please shoot. Yeah, and we will do something else next week after.